Hello everyone and welcome to the Birds and BBV Bites. My name's Veronica. I work at the Aboriginal Health Council of WA, and I thought today that we might do a bit of a refresher on STIs, and we're going to look at chlamydia, gonorrhea and trichomonas. And before we start, I would like to acknowledge the traditional custodians whose ancestral lands we gather on, the Whadjuk people of the Noongar Nation, and the ancestral lands where people are dialing in from today. I acknowledge the deep feelings of attachment and relationship of Aboriginal people to their culture and to their country and to their waterways, and I wish to pay my respects to all elders past and present and extend that respect to all Aboriginal people who have joined us today. So thank you. So if we look at chlamydia and gonorrhea under the microscope, here's what they look like. Chlamydia caused by a bacteria called Chlamydia trachomatis, and it has an incubation period of anywhere between 2 and 60 days. As gonorrhea, also known as Neisseria gonorrhea, has an incubation period of anywhere between 1 and 14 days, so a lot shorter. And for a lot of men, it's usually around 2 to 5 days. At the moment, rates of chlamydia amongst Aboriginal Torres Strait Islander people here in WA is around 4 times higher, and for gonorrhea around 14 times higher. So rates of chlamydia have sort of remained fairly steady over the past couple of years. As you can see there, I've got rates from 2020 to 2022. My apologies for the small writing. And we get anywhere between 800 to 1,000 notifications of chlamydia every month here in Western Australia. Gonorrhea, a bit up and down, anywhere between 200 and 300 notifications of gonorrhea per month. It has been up and down over the past couple of years. It did dip down there 2020 to 2021. I mean, it was COVID, but then you would have thought chlamydia would have dipped down there as well, which it didn't. Look, you know, there's also PrEP, which is pre-exposure prophylaxis for HIV, which is a fantastic preventative that people can take if they are perhaps going to put themselves at risk of HIV transmission. So, and I guess, you know, as you know, as the case, if you're on PrEP, maybe less likely to use condoms. So there we did see a bit of a rise in STIs as well due to the introduction of PrEP. So chlamydia, these are the notifications for the second quarter of 2022. So chlamydia up there in the 2000s, gonorrhea 772, and infectious syphilis, we had 240 notifications. So that's only the second quarter of 2022. I wanted to show you this slide. This is actually, although a little bit old, it's actually the last annual report in 2020. And this one shows you chlamydia notifications via age group and gender, and females are higher amongst the 15 to 25-year-olds than males. So females there are higher than the males, and it's more than likely because women in that age group are more likely to present to a health service for reasons such as contraception, maybe their menstrual cycle, antenatal care. So there are all sorts of reasons there, perhaps why the rates are higher. Women are going to present to a health service more so than a male. And there was research done a few years ago which actually showed women present to a health service around 4 times a year, as a male only once a year. Hence why I want to show you the next slide, which I thought would have been sort of very similar to chlamydia, but actually with gonorrhea, it's the opposite. And it is, we have notifications more so amongst males than females, and that's because males are more symptomatic than females that have gonorrhea. So with gonorrhea, about 10 to 15% of men will be asymptomatic. So that makes 85 to 90% of men would know that they have gonorrhea. And we'll talk about those symptoms a bit later on in another slide. As females are less likely to be symptomatic and will be asymptomatic with gonorrhea. So I think it's about half and half for females. So, for those watching from out in the regions, I thought you might be interested in some of your and some of the rates from out there. So, as you can see, metropolitan rates are the highest. Of course, we've got the largest population, and these are chlamydia notifications from the 30th of June. The 1st of July 21 to the 30th of June 2022. And then in the other column is the previous 12 months. And you can see that rates really haven't changed much over the previous 2 years. If we look at gonorrhea notifications in Western Australia by region for the two most recent 12-month periods, again, there has been a drop in gonorrhea in some regions. For example, the Goldfields there has dropped from 244 to 191. The Kimberley had 536 notifications down to 435 in the last 12-month period. Pilbara had a bit of an increase there, around 30 extra notifications there from the Pilbara in the last 12 months. Yeah, so that's sort of what's happening around in the regions. So how is chlamydia and gonorrhea transmitted? So I've got it written as CT. You might see that actually on a pathology form. It stands for Chlamydia trachomatis, and the NG is Neisseria gonorrhea. It is passed on vaginally, through vaginal sex, anal sex, oral sex, and mother to baby. And for Trichomonas, which we will talk about in another slide, it's mainly transmitted through vaginal sex and also through mother to baby. So how would you know if you had chlamydia? And how would you know if you had gonorrhea? So as I said before, with gonorrhea, about 80% of women actually don't have symptoms of gonorrhea, as 10 to 15% of men have no symptoms. But with chlamydia, about 75% of women will have no symptoms and 50% of men will have no symptoms. If you were going to have symptoms and you were a man, particularly with gonorrhea, you would have pain when passing urine. And they say that the pain is like pissing razor blades. It's really, really painful. And that would be the reason why a lot of men would take themselves to the clinic, because it just hurts so much when they pee. They may get a discharge from their penis, and it might be like a purulent type of discharge. For anyone with a vagina, you can also have a vaginal discharge, which could also be a purulent discharge with gonorrhea. Chlamydia is a little bit different. It produces more of a clearish type of discharge and can often go unnoticed. A female may also experience change in her periods, maybe spotting in between her periods, maybe spotting after intercourse. So that could be also a sexually transmitted infection. So anybody with those symptoms should be checked for STIs. Perhaps pain while having sex. This could indicate maybe early stages of pelvic inflammatory disease. So always, anyone with pain during intercourse should be checked for sexually transmitted infections as well. A male presenting with swollen testes, it could also mean that the infection has gone into the testicles, into the epididymitis, and they can get in epididymis, and they can get epididymitis. For for example, gonorrhea or chlamydia within the rectum, it can actually cause like disturbed bowel function and maybe pain when defecating or having your bowels open. Also, with oral sex, you can actually get the throat infection as well from chlamydia or gonorrhea, which can cause a pharyngeal infection. And I put conjunctivitis there as well because, again, babies who are born through the vaginal canal of a mum who has gonorrhea or chlamydia can pick up the infection. Particularly a gonococcal eye infection is very serious for an unborn baby if a mum has got gonorrhea that's been untreated. Okay, so with chlamydia and gonorrhea and trichomonas, sometimes, most of the time people can look and feel fine. We want to test at every opportunity that we can, and an STI test involves we need urine. If you're someone with a vagina, to get a swab, that's really important. It's probably the best test, but if the person doesn't feel comfortable taking a self-obtained low vaginal swab, then just a urine is fine. You need the first part of the stream, about 20 mils, because that is the part of the stream that will wash out any bacteria that is sitting there in the urethra or in the vaginal canal. So that's it. That's a get a urine. If you're someone with a penis, you want to get a urine. Now, if the male has just passed urine and can't pass urine and doesn't want to wait to pass urine, then you can actually get a swab of the male, another piece, a dry swab of the urethra as well. And like any STI test, it is not complete without bloods for syphilis, and also Hep B and Hep C if indicated. So there are lots of opportunities that we can offer testing. Just anyone aged between 15 to 35, we should be offering this age group a test around twice a year. And that is recommended by the Department of Health for anybody aged between 15 to 30. I know a lot of our Aboriginal community controlled health services have upped that age group and would like to actually, normalise testing for the 15 to 35-year-olds. We offer an STI test and a bloodborne virus test in a 715 health assessment. For women who are pregnant, we offer STI and bloodborne virus testing as a routine part of antenatal care and also throughout the pregnancy as well. For women of childbearing age, it's also a great opportunity to offer testing for STIs and bloodborne viruses to make sure that person is actually free from STIs prior to becoming pregnant. Anytime that someone's changed a partner, a really good opportunity to offer a test. Contraception, anyone coming in for contraception, again, they're already telling you that they're either sexually active or want to become sexually active. So great opportunity as well, and really shouldn't offer contraception without doing an STI and bloodborne virus check beforehand. Men who have sex with men, another cohort that are at higher risk of STIs and bloodborne viruses, so offering that to them. Unexplained arthritis, which I'll go through a little bit at a later slide, but that could indicate that it could be gonorrhea that has become septic. So how do we test for chlamydia and gonorrhea and trichomonas? So we can do the urine, which I talked about, and that urine, which is the 20 mils of first part of the stream, can actually test for all three, chlamydia, gonorrhea and trich. The vaginal swab, which I've also talked about, which can be self-collected and is the preferred way for anyone with a vagina. The urethral swab, as I talked about for the male, and if he doesn't want to, you can do, sorry, that's if the male doesn't want to pass urine, you can do the urethral swab. My apologies, I was looking ahead of myself there. If you've got a T-Tango machine, you can actually get a result in 90 minutes for chlamydia, gonorrhea, and 45 minutes for trichomonas. So absolutely fantastic if you've got a T-Tango machine in your service. If it's sitting there not being used, pull it out. It's a really fantastic asset to any health service, particularly those that are working more remotely when it takes a lot longer for you to get your test results back. Remembering anal swabs and throat swabs for people that have indicated that they're having anal sex or oral sex. And with the anal swab, again, it's a dry swab, but if you just wet it beforehand with a bit of sterile water or saline, and then pop it back into the tube once you give it to your patient. Obviously, if they need to take a couple of swabs in with them to maybe use some sort of indication around which one is an anal swab, which one is the urethral swab, and which one is the vaginal swab. I know some services use a coloured sticker or something like that to make sure that the patient knows which swab is for which sample, and that's really important. Anybody that has a discharge, it's super important to get a swab for culture whenever possible, so that antimicrobial susceptibility can be obtained. Now, I know that can be difficult for people who work in remote areas because it's so important that swab gets to the lab within 24 hours, and I know that's not always the case. So I guess my advice is still do a swab and send it away. It may be, most likely that whatever was on it has been diminished. However, still send it because you never know. And you can always, but please send your dry swabs. Okay, so what is the treatment for chlamydia and gonorrhea? So in the Kimberley, Pilbara and Goldfields regions, we still use the Zap Pack, which is 10 tablets of, so it's azithromycin, amoxicillin and probenecid. So we still use those for both chlamydia and gonorrhea infection. So if your patient just has chlamydia and not gonorrhea, then you can treat them with azithromycin, 2 tablets of 500 milligrams. Gonorrhea has become penicillin resistant outside of those areas. So for us here in the metro and down south, we need to actually treat using ceftriaxone. And that is an injection that we have to mix with local anaesthetic. And we also give it with 2 tablets of the 500 milligrams of azithromycin. So that is how we treat gonorrhea here in the Metro Southwest, Wheat Belt, and also the Midwest also it treats that way as well. Patients should be advised to have no sexual contact for 7 days after completion of treatment and to avoid sexual contact with any partners from the past 6 months until 7 days after they have been tested and treated. And chlamydia co-infection rate among patients with heterosexually acquired gonorrhea is around 40%. Hence why we actually treat with azithromycin and the amoxicillin in the Kimberley, Pilbara and Goldfields, and then also for us that have to use ceftriaxone, we also add the azithromycin in. Trichomonas, sorry, I haven't actually talked much about trich at the moment. Obviously, it's so fantastic that we can add Trichomonas onto the same samples that we use for chlamydia and gonorrhea. I don't have any stats on this because it's actually not a notifiable disease, so therefore it is not sent to the health department, epidemiology department. It is very common though in rural and remote regions of WA, and I know that there are many Aboriginal community controlled health services in those areas, and also other health services that just add Trichomonas on because they know that there are sort of higher cases in their regions. Symptoms of Trichomonas can be, for females, sort of an irritating, sort of smelly discharge that can be a bit frothy, and it's quite an annoying discharge. It's quite difficult to get rid of. You can wash yourself and the smell sort of doesn't go away, and that's often why you present for treatment. But with men, there's often no symptoms. We test pregnant women for trichomonas in those regions where we find trich at its highest because it can actually cause premature rupture of membranes, as can chlamydia and gonorrhea infection as well in a pregnant woman. So the infections can go up inside the vagina through the cervix and then irritate the bag of waters where the baby is, and that can actually cause the bag of waters to break and then cause preterm labour. Like any infection, Trichomonas can also put somebody at increased risk of HIV transmission. We know the best protection against viruses such as HIV is an intact skin and intact mucous membrane, but where we have fine breaks, inflammation, those sorts of things, then we're actually opening up a portal for viruses such as HIV to get in. So as I said, the testing for trich is the same as for chlamydia and gonorrhea, and the treatment is metronidazole, and we usually give 2 grams stat. And just really important to advise your patients that just to avoid alcohol after taking metronidazole, because it actually can make them feel very unwell. Probably one of the biggest parts of our jobs working in sexual health is contact tracing. It's often really difficult. Contacts often don't understand why they've been named as a contact or why we might be chasing them as a contact, because they will say, I don't have any signs and symptoms, so how would I have something like that? But we know that so many people don't have any signs and symptoms and they can be carrying and transmitting the infection. So it's really important to relay that information that so many STIs don't show any symptoms, and the best way to often know is to get a test. We do ask patients that have been diagnosed with an STI to actually let us know, or they may want to let their contacts know, and to go back 6 months so that they can actually contact those people and let them know that they need to be tested and treated as well. It's best to get checked, and remembering that an STI test is not complete without bloods for syphilis, HIV, and other bloodborne viruses. Honestly, contact tracing is probably another whole birds and BBV bite in itself. And probably the best advice that you can get around contact tracing is talking to those people that work in regional and remote areas who do this every day. It's part of their job, and they find ways to really get the message out there. But I think one of the key things that I've learnt is to tread slowly and to build rapport and relationships with your community, and that always helps when it comes to contact tracing. And of course, as we all know, confidentiality is the key. So what happens if you don't get treated for chlamydia and gonorrhea? Um, well, I mean, we talk about, problems with your health if you don't get treated for your STI, and we talk about infertility as a reason for untreated STIs. And so I thought I'd just share this slide with you. It sort of goes a bit deeper into what does actually perhaps occur with infertility. And so when somebody has an STI and it goes up inside the reproductive system, for example, of a female, it finds its way into the very, very narrow fallopian tubes. And this is where it can play havoc in these tiny tubes and cause the infection. The infection can then spread all the way along the tube, and you can actually have pus actually coming out the end of the fallopian tube and making its way into the pelvic canal. This can cause what's called pelvic inflammatory disease. It's actually a health emergency. That person would be in extreme pain and needs to be treated immediately, as in a tertiary hospital. Usually they need IV antibiotics to treat the infection. The same for a male as well. It can actually go into their testes and can cause swollen testes, which are extremely painful. And again, they need immediate antibiotic treatment. Now, once they've been treated, the infection responds very well and can go away. It can take some time though, but it can leave these scarring, or these sort of violin strings behind. And those violin strings can be in the fallopian tubes, and they can also be in the pelvic canal as well. Now, when it's time, for that person maybe to choose to start a family, or they've got a pregnancy, what can actually happen is the pregnancy can get stuck in the tubes due to the scarring, and this can cause what's called an ectopic pregnancy. So, an ectopic pregnancy can be the result of PID, after PID. Now, it doesn't mean that everybody who's had an ectopic pregnancy has had an untreated STI and PID, because some people are just born with narrow tubes. But if you have repeated STIs that are, not treated and then you have an STI again and then it's treated, maybe you've had PID a couple of times, the risk gets higher and higher of this scarring occurring. So it's just so important that we offer routine screening for STIs so that we can diagnose these STIs early and get people treated early to try and avoid these complications later on in life. So other complications of untreated STIs, as I discussed, babies can be born early. Babies coming through the canal of a woman who has an STI in her vagina, such as chlamydia and gonorrhea. Chlamydia tends to maybe cause like a pneumonia, if the baby should suck in the pneumonia to their lungs. Serious eye infections, that little baby at the top there has got a gonococcal eye infection. And the picture below is actually an adolescent who presented with an eye infection. It turned out they had gonococcal eye lesions on the eye and also a purulent discharge. I mentioned before about gonococcal arthritis. So again, untreated gonorrhea can go in to the body, and the person can become what's called septic, and the gonorrhea can then go to the joints and cause this arthritis. So a high clinical suspicion is necessary for patients who present with joint pain or swelling that is concerning for septic arthritis, especially anyone who's young. Like around under 40 years old, and is a certain risk population, such as men who have sex with men, or in those areas where you've got high rates of gonorrhea. That picture there is also, you can get these gonococcal lesions on your skin. They're not very common at all. In fact, they're quite rare, but I thought I'd just show you that as well. So you're at risk of sexually transmitted infections such as chlamydia, gonorrhea, and trich. If you're having sex without a condom, and that's vaginal sex, anal sex, oral sex. If you're an unborn baby and your mum has it. If you're sharing sex toys, remembering sex toys can also harbour infections as well, probably more likely to be something like Trichomonas, but other STIs you've got to be mindful of as well. Best thing to do is wash the sex toys in warm soapy water, and you can always use a condom over your sex toy as well as a form of prevention. Anyone who's been in prison could be at risk of sexually transmitted infections as well. If you're having unprotected sex for drugs, if you're having unprotected sex for somewhere to sleep, you're at risk. If you don't have access to condoms or dental dams, you could be at risk, or you don't know where to get a test. Maybe you feel too ashamed to get checked. This is why it's so important that we offer STI testing routinely, normalising it, making it part of a routine health check, offering it to that male who you may not see again for 12 months, because often men only present to a health service maybe once a year. We want to offer it to pregnant women, and not just at their first antenatal visit, but we want to offer it along the way. And we know that with syphilis, we need to actually test pregnant women at first antenatal check, 28 weeks and 36 weeks, and then at birth and 6 weeks later. So we need these regular checks for syphilis. So also offering them tests for other STIs as well, if that's indicated, is a really good idea. STI testing, it used to be piss easy. Well, we need blood now because of the need for syphilis, HIV, and bloodborne viruses. So It's so important to get both. If a person doesn't want you to take their blood, I mean, obviously you can't force them. So, if you can just get a urine or a swab or both, then that's a pretty good start. All the information that I've shared with you today, I've got from the Silver Book, and it's also the Sexual and Health Orientation Manual for Endemic Regions 2019. I think it's actually 2016, to be honest, for that one, but I'll double check that out. And that's it. That's today's bite. I hope you enjoyed it. Any questions, please do not hesitate to contact me here at Aqua. I have recorded this bite and will be available on the Aqua website and our YouTube channel. So thanks very much for joining me. And I'll see you again at our next bite. Okay, see you everyone. Bye.